Hi, good night, everyone. I am Sherry Sargent, and tonight we'll be doing part two of this lecture series on hematolymphoid tumors involving the central nervous system. So, hematolymphoid tumors involving the CNS. We'll start off with the primary diffuse large B-cell lymphomas of the central nervous system. These may be histologically identical to secondary CNS spread of systemic diffuse large B-cell lymphomas, and they are suspected with a homogeneously enhancing lesions in the central gray matter or the corpus callosum on MRI or CT, especially in patients with acquired immune deficiency syndrome or AIDS patients, and they may present with multiple cranial nerve palsies. The diagnosis is highly likely if the tumor is seen in conjunction with uveitis, and they are very responsive initially to steroids, and they are short-lived disappearance and also known as ghost tumors. The treatment is usually with a combination of radiation and chemotherapy, and the role of neurosurgery is usually limited to biopsy and or placement of a ventricular access or reservoir for chemotherapy, and occasionally to debulk an extremely large tumor causing severe symptoms. The risk factors are patients that are immunosuppressed, such as AIDS or transplant patients, patients with Epstein-Barr virus or collagen vascular diseases. So these are also known as primary central nervous system lymphomas, and CNS involvement with lymphomas may arise primarily or occur secondary from a systemic lymphoma invading the central nervous system. A lymphoma confined to the central nervous system at presentation that has a histological feature and many molecular findings that replicate those of systemic lymphomas. 65% are solitary lesions, with the remainder being multifocal. So the diagnostic criteria for primary diffuse large B-cell lymphomas of the CNS would include the essential criteria: a biopsy-proven mature large B-cell lymphoma confined to the CNS at presentation, and the expression of one or more of B-cell markers, for example, CD20, 19, 22, 79A, or PX5. So primary versus secondary lymphomas. Secondary CNS lymphomas, these are non-CNS lymphomas and is the fifth most common cause of cancer deaths in the US. 63% of new cases are non-Hodgkin's lymphomas, and secondary CNS involvement usually occurs late in the course. Metastatic spread from a systemic lymphoma to the cerebral parenchyma occurs in 1 to 7% of cases on autopsies. And with regard to primary CNS lymphomas, the older names would include reticulum cell sarcomas or microgliomas, since they were thought to possibly arise from microglia, which were considered part of the reticular endothelial system. A rare malignant primary CNS form of non-Hodgkin's lymphoma comprising of 0.85 to 2% of all primary brain tumors and 0.2 to 2% of malignant lymphomas, and they may occasionally metastasize outside of the central nervous system. So these specific types of primary CNS lymphomas, we would discuss the diffuse large B-cell lymphomas of the central nervous system. These exclude any of the lymphomas listed below, as well as lymphomas with systemic involvement, immunodeficiency-associated CNS lymphomas, um, intravascular large B-cell lymphomas, miscellaneous rare lymphomas of the CNS, including low-grade B-cell lymphomas, T-cell and NKT cell lymphomas, and anaplastic large cell lymphomas. And the fifth one, extranodal marginal zone lymphomas of mucosa associated lymphoid tissue or MALT lymphomas of the dura. So the epidemiology, the incidence of primary CNS lymphomas in the US is approximately 0.44 per 100,000, making it the third most common malignant primary brain tumor behind GBMs and diffuse astrocyte tumors. In the last 20 years, the incidence has increased in patients greater than 60 years of age, and the male to female ratio is 1.22 to 1.5. The median age of diagnosis is 52 years, and younger amongst the immunocompromised patients are 34 years. The most common supratentorial locations would include the frontal lobes, then the deep nuclei, and the periventricular region is also common, and infratentorially, the cerebellum is the most commonly located. So conditions with increased risk of primary CNS lymphomas, these would be the collagen vascular diseases such as SLE, Sjogren's syndrome, which is an an autoimmune connective tissue disorder, and rheumatoid arthritis. Immunosuppression, this can be from organ transplant patients with related to chronic immunosuppression and falls under the category of post-transplant lymphoproliferative disease. Patients with HIV and AIDS, CNS lymphomas, they occur in approximately 10% of AIDS patients and is the first presentation in 0.6%, and severe congenital immunodeficiency syndromes, and possibly increased incidence in the elderly due to reduced competency of the immune system. And thirdly, Epstein-Barr virus is associated with a broad spectrum of lymphoproliferative disorders, and it is detectable in approximately 30 to 50% of systemic lymphomas. However, it has been associated with almost 100% of the primary CNS lymphomas, especially in AIDS-related cases. So the presentation. This is similar with primary or secondary CNS lymphomas, and the two most common neurological manifestations are those due to epidural spinal cord compression or those of carcinomatosis, meningitis, with multiple cranial nerve deficits. Seizures occur in up to 30% of patients, and most lymphomas in patients first presenting with neurological symptoms are the primary CNS lymphomas. So the neurological symptoms, they can present with non-focal, non-specific symptoms. Over 50% of patients at the time of presentation most commonly includes a mental status change in one-third the patients, symptoms of increased ICP with headaches, nausea and vomiting, and generalized seizures in 9% of patients. Focal symptoms occur in 30 to 42% of cases, and these can include hemimotor motosensory symptoms, partial seizures, or multiple cranial nerve palsies due to carcinomatous meningitis. And then you can have a combination of focal and non-focal symptoms. So these signs, non-focal, in 16% of patients can include papilledema, encephalopathy, or dementia. And the focal findings can occur in 45% of cases. These are the hemimotor, hemisensory deficits, aphasia, and visual field deficits, and the combination of focal and non-focal signs. So uncommon but characteristic syndromes would include the uveitis, which is coincident with in 6% of cases or preceding the diagnosis of in 11% of lymphomas where there's spread to bilateral orbits, and subacute encephalitis with subependymal infiltration, and MS-like illness with steroid-induced remission. The histology, common sites would include the corpus callosum, basal ganglia, periventricular regions, and the neoplastic cells are indicated to those of systemic lymphomas. Most are bulky tumors that are contiguous with the ventricles or meninges, and the histologic distinguishing features would include tumor cells forming cuffs around the blood vessels, which demonstrates multiplication of the basement membranes. And this is best demonstrated with the silver reticulum stains. Frozen section distorts the cells and they may lead to misdiagnosis of a malignant glioma. Immunohistochemical stains differentiate B-cell lymphomas from T-cell lymphomas. The B-cell types are more common, especially in primary CNS lymphomas and in AIDS. With electron microscopy, it shows the absence of junctional complexes or desmosomes that are usually present in the epithelial-derived tumors. So moving on to intravascular lymphomatosis, which is formerly known as malignant angioendotheliomatosis. This is a rare lymphoma with no solid mass in which malignant lymphoid cells are found in the lumen or small blood vessels in the affected organs. CNS involvement is reported in most cases. So the presentation is really non-specific. The patients are often febrile and may present with progressive multifocal cerebrovascular events, including stroke or hemorrhage, spinal cord or nerve root symptoms, including Corda-Equina syndrome, encephalopathy, or peripheral or cranial neuropathies. Initial transient cerebral symptoms may mimic TIAs or seizures, and ESR is often elevated prior to the initiation of steroids. So lymphoma cells may be also seen in the CSF. So painful skin nodules or plaques occur in approximately 10% of cases and generally involving the abdomen or lower extremities. And these cases may be diagnosed with a skin biopsy. Differential diagnosis here includes angioendotheliomatosis, a benign capillary, or an endothelial cell disorder. The diagnosis often requires a brain biopsy, either open or stereotactic, in which the involved area or image studied are targeted. So the pathology, malignant lymphoid cells distend and occlude the small arteries, veins, and capillaries with little or no parenchymal extension. The treatment is a combination of chemotherapy. This could result in a long-term remission in some patients, but early diagnosis before permanent damage occurs is key and critical. So the diagnosis is rarely made pre-mortem. So how do we evaluate these patients? All patients should be assessed with a thorough history, physical examination, and laboratory tests as appropriate for any of these conditions associated with lymphomas. Since primary CNS lymphomas are less common than secondary involvement, any patients with CNS lymphomas should have a workup for an occult systemic lymphoma, which may occur. So, careful physical examination of all the lymph nodes, early detection of HIV and CD4 positive reflex count are important because HIV increases the risk of primary CNS lymphomas and infection. A contrast CT of the chest, abdomen, pelvis, or whole body PET-CT for evaluation of the perihilar pelvic lymph nodes. Routine blood work, such as a complete blood count and biochemistries and urine testing, lumbar puncture for CSF analysis. It's important to omit if it's not safe, i.e., anticoagulation, thrombocytopenia, or intracranial mass effect being present. And for routine tests on CSF, such as cell count, protein, glucose, culture, and cytology and flow cytometry. A bone marrow biopsy as well, an MRI of the entire neuroaxis. Testicular ultrasounds in males greater than 60 years of age, and we can omit this though if a PET scan is done and it's negative. And then there's the ophthalmic examinations, including a slit lamp evaluation of both eyes for possible uveitis. So the diagnostic tests, CT and MRI, will be discussed here, and the findings common to both would include on CT or MRI, 50 or 60% occurs in one or more cerebral lobes in the gray or white matter. 25% occur in deep midline structures such as the septum pellucidum, basal ganglia, or corpus callosum. 25% are infratentorial. 10 to 30% of patients have multiple lesions at the time of presentation, and in contrast, systemic lymphomas that spread to the CNS tend to present with leptomeningeal involvement instead of parenchymal tumors. Almost all primary CNS lymphomas enhance, and except only 1.1% in the immune intact patients and 3.2% in the immunocompromised patients. In non-AIDS-related cases, they tend to enhance homogeneously, where AIDS-related cases are more likely to be ring-enhancing with a necrotic center and multifocal. In non-AIDS-related cases, CNS lymphomas should be suspected with homogeneously enhancing lesions in the central gray or corpus callosum. 75% are in contact with ependymal or meningeal surfaces, and this together with dense enhancement may improve a pseudomeningioma pattern. However, lymphomas lack calcification and they are more likely to be multiple. So with regard to CT scans, 60% are hyperdense to the brain, only 10% are hypodense. Characteristically, approximately 90% of these tumors enhance. This is densely homogeneous in over 70%, and as a result, when rare non-enhancing cases occur, it often leads to a delay in the diagnosis. So the appearance of an enhanced primary CNS lymphoma on a CT has been likened to a fluffy cotton ball appearance. There may be surrounding edema, and there's usually mass effect, and in almost there's an almost diagnostic tendency of rapid, partial to complete resolution on CT, and even at the time of surgery following the administration of steroids, earning the nickname the ghost cell tumor on disappearing tumors. So on MRI, there are no pathognomonic features. It appears bright on DWI or restricted diffusion in most cases, isotense or hypointense on the ADC map, and it may be difficult to discern if the tumor is located subepidymally with signal characteristics similar to CSF, and proton weighting imaging may avoid this limitation. So serological tests. These are there are no blood tests that are diagnostic for primary CNS lymphomas. However, with serum lactate dehydrogenase, elevation indicates rapid cell turnover, and it is an independent poor prognosticator for non-Hodgkin's lymphomas, follicular and mantle cell lymphomas. In the absence of the diagnosis of a lymphoma, this is non-specific, as it occurs commonly in liver failure and infection. So CSF studies. And lumbar puncture should only be performed if there is no mass effect. To reiterate, some abnormality of routine CSF labs occur in 80% but are not specific, and most common abnormalities are elevated proteins in 45 to 67%, and it increases cell count in 40%. Primary CNS lymphomas can lower CSF glucose as well. So cytology is positive for lymphoma cells preoperatively in only 2 to 32%, with a sensitivity maybe higher with leptomeningeal involvement, as in non-AIDS patients, that with parenchymal involvement commonly seen in AIDS. Sensitivity is higher when there's more than 10.5 mils of CSF analyzed, and repeating up to 3 LPs may increase the yield. The morphology of the lymphoma cells can sometimes be difficult to distinguish from inflammatory lymphocytes, but sharp nuclear notches, cytoplasmic irregularity, and increased cell size greater than 2.5 times the upper limit of normal are suggestive of a lymphoma. Although the diagnosis of lymphoma can be made from CSF cells obtained under or in this manner are not adequate for detailed tissue typing, which is possible with only a solid tissue biopsy. Therefore, LP alone rarely suffices. So flow cytometry provides information about the immunophenotype of the lymphocytes, and immunoglobulin analysis can show a single elevated immunoglobulin heavy chain or IgH band with lymphomas when compared to a wide band produced by lymphomas involved in an inflammatory process. So the proteomics have shown elevated levels of antithrombin 3 in the CSF and a cutoff level of greater than 1.2 mcgs per deciliter is 75% sensitive and 98.7% specific. Angiography. So angiography is really helpful, and 60% of cases show only an avascular mass. 30 to 40% show diffuse homogeneous staining or blush. Moving on now to immunodeficiency associated CNS lymphomas. So, a family of CNS lymphomas occurring in patients with inherited or acquired immunodeficiency, either HIV, AIDS, or immunosuppression, and the number of cases related to AIDS has declined due to the effectiveness of newer antiretroviral therapy. Most immunodeficiency associated lymphomas are Epstein-Barr virus related, and EBV positive diffuse large B-cell lymphomas of the elderly is coupled with immunosense and starts to ramp up after the age of 50 years. Imaging demonstrates multiplicity of lesions and necrotic areas more frequently in the immunocompetent patients. So the diagnostic criteria for immunodeficiency-associated CNS lymphomas, the central criteria is a B-cell lymphoma contained to the CNS at presentation in an immunodeficient patient, and EBV positivity of the tumor cells demonstrated by immunohistochemistry or in situ hybridization. What is desirable is the demonstration of a clonal B-cell population by PCR in diagnostically difficult cases. So treatment. Surgical decompression with partial or gross total removal does not alter patient's prognosis, and the main indication for surgery is a biopsy to obtain solid tissue to ascertain that the tumor is a lymphoma and to determine the type of lymphoma. Stereotactic techniques are often well suited for these often deep tumors. The role of radiation therapy and chemotherapy. So radiation therapy, this is the standard treatment after the tissue biopsy, is whole brain radiation therapy, and the doses used tend to be lower than for other primary brain tumors. So approximately 40 to 50 Grs total are usually given in 1.8 to 3 Grs daily fractions. Chemotherapy in non-AIDS cases combined with and chemotherapy combined with radiation therapy prolongs the survival when compared to radiation therapy alone. So to touch a little bit on methotrexate and rituximab. So methotrexate, the addition of intraventricular methotrexate rather than just an intrathecal via lumbar puncture delivered through a ventricular access device, where 6 doses of 12 milligrams twice a week with IV leucovorin rescue, it may result in even better survival. And rituximab has been available since 1997 for the treatment of refractory systemic B-cell non-Hodgkin's lymphoma, and intrathecally may be more effective for CD33 positive lymphomas. So prognosis. With no treatment, the median survival is 1.8 to 3.3 months following the diagnosis. With radiation therapy, the median survival is 10 months, with 47% 1-year median survival and 16% 2-year median survival. The 3-year survival is 8%, and the 5-year survival is 3 to 4%. With intraventricular methotrexate, the median time to recurrence was 41 months, and occasionally prolonged survival may be seen. About 78% of cases recur, usually in approximately 15 months, and after treatment, and late recurrences are also seen. Of these recurrences, 93% are confined to the central nervous system, often at other sites if they are often at other sites if the original site responded well, and 7% are elsewhere. Although there are individual studies that show these trends, there are no prognostic features that are consistently correlated with survival. With regard to prognosis, the prognosis is worse than central nervous system tumors, the diffuse large B-cell lymphomas. And although complete remission occurs in 20 to 50% following radiation therapy, the median survival is only 3 to 5 months, usually related to AIDS-related opportunistic infection. However, the neurological function and quality of life improve in 75%. And the last section will be focusing on the histiocytic tumors. Histiocytic disorders may be classified as malignant, which are the true histiocytic tumors, reactive, which are benign histiocytosis. 3, the Langerhans cell histiocytosis. This could be unifocal or multifocal. The unifocal, formerly the eosinophilic granuloma, and or the histiocytosis X. And it's rare with one in 1,200 new cases per year in the US. It's more common in children and a slowly progressing disease, and it may occur in bone, skin, lungs, or stomach. The multifocal unisystem, it's seen mostly in children, and it occurs in with fever and in bone and skin lesions. And there's the multifocal multisystemic, which is formerly the Latera-Su disease, and it is a fulminant malignant lymphoma of infancy. The Hans-Schuler-Christian triad, where there is DIA from invasion of the pituitary stalk, exophthalmos from intraorbital tumor, and lytic bone lesions, particularly in the cranium. Fourthly, there's the Erdheim-Chester disease, Rosé-Dorfman disease, juvenile xanthogranulomas, and histiocytic sarcomas. So Langerhans cells histiocytosis of the CNS or meninges. This, as mentioned before, is formerly known as histiocytosis X or the eosinophilic granuloma when solitary. It is a clonal proliferation of the Langerhans type cells involving the CNS, skulls, or meninges with or without extra CNS lesions. 30% of patients develop a leukoencephalopathy pattern, and 8% demonstrate cerebral atrophy. The location, there is a predilection for craniofacial bones and skull base, and 56% favoring the parietal and frontal bones. And intracranial involvement may include the hypothalamic pituitary region with 25 to 50%, the meninges in 30% and the choroid plexus in 6%. So the diagnostic criteria for Langerhans cell histiocytosis essential would be a population of cells showing cytological features of Langerhans cells and expressing CD1A and or CD207 Langerhans. And the desirable features is the ones with the data S100 positivity and BRAF and MAP2K1 mutation status. So the epidemiology, it's generally a condition of the youth where 70% of patients are under 20 years of age. In a series of 26 patients, the age range was 18 months to 49 years with a mean of 16 years. The incidence among patients less than 15 years of age is 0.5 per 100,000 with a male to female ratio of 1 to 2.34. And clinically, the most common presenting symptom is a tender enlarging skull mass in 90% of cases, and it may be asymptomatic and incidentally discovered on the skull x-rays obtained for no other reasons. Blood tests were normal, all except one who had eosinophilia of 23%. So the evaluation with regard to skull x-rays, the classic radiological finding is round or oval non-sclerotic punched out skull lesions with sharply defined margins involving both inner and outer tables, and the disease begins in the diploic space, often with beveled edges. A central bone density is occasionally noted, rare but diagnostic, and no abnormal vascularity or adjacent of the adjacent bone, and no periosteal reaction as well to differentiate from hemangiomas by absence of the sunburst appearance. And on CT scans, the characteristic appearance of a soft tissue mass within an area of bony destruction having central density, and it differentiates from the epidermoid, which has a dense surrounding sclerosis. So the pathology, the gross specimen would be a pink, gray to purple lesion extending out of the bone and involving the pericranium, and the dural involvement occurs in 1 of 26 patients, but with no dural penetration. Microscopic, there are numerous histiocytes, eosinophils, and multinucleated cells in the reticulin fiber network, with no evidence that this is a result of an infection. And from the molecular biology, the most frequent molecular correlation is the BRAF-P V600E mutation, which is seen in 50%. So the treatment, there's a tendency towards spontaneous regression. However, most single lesions are treated by curettage, and multiple lesions are usually associated with extracalvarial bone involvement and are often treated with chemotherapy and or low-dose radiation therapy, and they are very radiosensitive. And the outcome after a mean 8-year follow-up, 8 patients, that is 31%, develop additional lesions. 5 of these were less than 3 years of age. All of 5 patients less than 3 years of age may suggest a form of multifocal Langerhans cell histiocytosis. Thus, young patients should be followed up very closely. And lastly, recurrences were local in one case, and in the others involve other bones, including the skull, femur, and the lumbar spine, or brain, including the hypothalamus, presenting with diabetes insipidus and the growth delay. So this brings me to the end of this presentation on hematolymphoid tumors involving the CNS. Thank you.